2, 3, 4, 5. At each step, people who are using SABA more frequently, and this is only 3 or more SABAs in a year, so that's still not very frequent use if you think to how often your patients are using it. If you're using it 3 or more times a year compared to 0 to 2 SABA inhalers per year, you're at significantly higher risk of asthma attacks in the future. So if we think of asthma control, one, this high use group has or is likely to have uncontrolled asthma because they've got symptoms that need relief, but also they're at risk of that second part of poor control, which is future risk of asthma attacks. So recognizing high SABA use as an indicator of poor asthma control and providing an opportunity for us to try and improve that asthma control, both to improve their symptoms in the present, but also to reduce their future risk of exacerbation. And of course, exacerbations are significant events. We also know that the more SABA that patients are picking up, the greater their risk of exacerbation in the future. So if you're 2 SABA canisters a year, you're a little bit higher risk than somebody with 0 to 1. 3 to 6 SABA canisters, that risk goes up a bit further. 7 to 12, that risk goes up a fair bit further. And if you're on more than 12, so more than 1 a month, you're really at quite significantly higher risk. So those using very frequent SABA and getting lots of SABA inhalers are really at very significantly increased risk of an asthma attack. So by definition, have poor asthma control. And it just makes sense, doesn't it? So if we imagine a patient coming along, they've got their blue reliever inhaler, they may or may not be taking the preventer inhaler that's been prescribed for them. When they get some symptoms, they use a puff of their inhaler to relieve those symptoms. And they may get some relief from those symptoms, particularly for minor episodes. The more significant those episodes, the more they'll be using their inhaler. Still may settle just with that normal variability. But what we're seeing is with that variability, by definition, those patients have uncontrolled asthma. And then, of course, when those events get more severe, they're using much more of their blue inhaler. So we can understand, I suppose, why frequent use of their blue inhaler reflects poor asthma control. If we think about an asthma attack in somebody on a fixed dose regime, so that might be just a steroid inhaler, 2 puffs twice a day, or an ICS LABA inhaler, 1 or 2 puffs twice a day, and then a blue reliever, when they're exposed to that trigger, we know that asthma is an inflammatory condition, so it's the inflammation that drives the symptoms. So that inflammation starts to creep up, the symptoms rapidly follow, and as those symptoms start to creep up, that individual starts to use their blue inhaler more frequently to try and relieve those symptoms. Meanwhile, the airway has gone from being nice and relaxed and open to becoming horribly inflamed and narrowed and with kind of phlegm and things within it. And understandably, this patient's getting more and more symptoms. And it gets to a crisis point where they're no longer feeling that they can manage just with their blue inhaler. They've used a fair bit of it already, and they end up either coming to see you in primary care or coming to see us in secondary care and ending up on some oral steroid tablets. And of course, the tablet steroids, pretty broad kind of blunderbuss approach, settle inflammation, and as the inflammation settles, the symptoms settle as well, and that person recovers from that exacerbation. But of course, they've had a course of oral steroids, and we know that oral steroids are associated with increased risk of long-term side effects. So again, coming back to that second element of asthma control, we're putting that person at risk of things like diabetes, cataracts, hypertension, osteoporosis, obesity, all of those kind of things which come with oral steroids. So we want to try and prevent this from happening, minimize it as far as possible. And of course, we do that when we're thinking about how do we manage our asthma patient, how do we achieve that asthma control. We defer to the guidelines, don't we, in terms of what they recommend. So just thinking about BTS sign, because I'm going to come to local guidelines in a second. BTS sign are very clear that inhaled corticosteroids are the mainstay of asthma treatment. They are there at every step. And of course, even those that are getting referred to specialist centres will be on inhaled corticosteroids. So they are at every step in the asthma guidelines, even in patients where you're initially suspecting asthma. So all asthma patients should be on an inhaled corticosteroid in one form or another. And then depending on whether control is achieved, then there's different drugs that can be added and different doses that can be escalated. But ultimately, it is inhaled corticosteroids that are the cornerstone of asthma treatment. And BTS sign also recognize that SABA is an indication of poor asthma control. So if someone's needing 3 or more doses per week, they suggest that we should be considering dose escalation. So we certainly need to get away from a way where, or a system where SABA can be used fairly freely and reissued fairly freely without prompting review to see how we can improve that person's asthma control. So what do our local guidelines say? So on the right-hand side here, there's some key principles at the top here. So one, we should try and achieve control with the lowest dose of drugs as possible. But importantly, we're striving for asthma control. And that we should make sure before we're considering stepping up or stepping down treatment, particularly before considering stepping up treatment, that the patient is actually able to and is using the treatment that they're already prescribed. So can they use their inhaler? What's their technique like? Is it effective? Are they actually getting that medicine into their lungs? Even if their technique's good, it doesn't work if it sits in the drawer. So are they actually taking it? And of course, a way that you can assess that in primary care is just looking at the prescription pickup rate. So are they picking up as many prescriptions for their preventer inhaler as you might expect? And now that Pheno is coming around, sometimes you can use Pheno to help with adherence. If somebody's got an elevated Pheno, then you can do a period where they take their inhaler each day, and possibly on a video call with somebody or monitored, and then you check the Pheno at the end of the week. And if it's dropped with that observed therapy, then it's likely they're non-adherent. So local guidelines suggest all asthma patients treated initially with an inhaled corticosteroid. That's very much in line with the national guidelines from BTS sign, and a low dose inhaled corticosteroid if they are taking it and it controls their symptoms and they're not exacerbating, not requiring frequent SABA, then that should be fine. If, however, they're still symptomatic, and even if they tell you they're not, if they're picking up their SABA more than 2 in a year, then they are symptomatic. They're just managing that with their inhaler. Then you should think about whether they need to escalate treatment. So at that point, we check their technique, we check their adherence, and if that seems reasonable, then we look at the next step up. And the recommended step up is to an ICS LABA combination inhaler using maintenance and reliever therapy as the first line. And that is for the vast majority of patients. For younger people, very atopic, or those with predominantly exercise-induced asthma, you might be tempted to try montelukast first before that ICS LABA. Those are the groups that tend to respond to that. But again, I'd have a low threshold for going to ICS LABA if not a good response. And the guidelines state, do not co-prescribe a SABA. And we'll come on to why that's important in a moment. So just the kind of key principles I've already gone through. We want to achieve asthma control. That's what we should be aiming for. We shouldn't be accepting anything less. We want to use the lowest dose of medicines possible. We always want to revisit inhaler technique, and we always want to revisit their concordance with therapy, because throwing more medicines at somebody if they're not taking the ones they're already prescribed probably isn't going to do the difference. So we need to try and address adherence first. The key principle of asthma is all patients with asthma should be on anti-inflammatory therapy. So an inhaled corticosteroid as a minimum. Emphasizing MART is there. So what is maintenance and reliever therapy? I appreciate many of you will already know, but a bit of a refresher. So maintenance and reliever therapy refers to the use of an ICS formoterol containing inhaler, and the combinations that you can use are those that contain either budesonide or beclomethasone as the inhaled steroid. So that's things like Foster and Fobumex with the beclomethasone, and things like Symbicort and Duoresp with budesonide, and combined with formoterol, all in the one inhaler. The reason that works is that the formoterol has a fast onset of action and therefore provides relief. It lasts longer than the SABA. And of course, there's an inhaled steroid in there as well. So you use it as your preventer and also as the reliever, which the formoterol helps with. And just to demonstrate to you that formoterol is an effective reliever, These are two different graphs showing exactly the same thing. One based on a study which used Symbicort, so budesonide formoterol, and another inhaler combination with Foster, beclomethasone formoterol. And what they did in these studies is they used a methacholine challenge, so where you challenge somebody's airway with getting them to inhale something which makes the muscle tighten. And you can see the drop in the FEV1, so the amount of air they can blow out in 1 second drops following that. And if you allow them just to recover naturally, they follow this line here with the placebo, so no medicine to help relax that muscle. They follow that line there. If you give them salbutamol, your SABA reliever, then you can see the muscle relaxes quite rapidly, and it's the black squares there. And if you give them budesonide formoterol, the only medicine in that will relax the muscle is the formoterol, you can see they follow exactly the same line as with the salbutamol. So you get the same rapid relaxation of the airway smooth muscle within minutes of it being taken, and it mirrors the salbutamol. This is the trial using Foster. In other parts of the world, it's called Foster, which is why it says that's not a typo. That unfortunately, it's an international study. But once again, the Foster with the formoterol follows a very similar trajectory. You might be convinced there's a bit of a difference here. There was no statistical difference in this, and it was followed very much the same trajectory in terms of relief as with the salbutamol. So formoterol does work as a reliever. It relaxes the muscle and it relieves the symptoms at the same pace and speed that salbutamol does. So how does it work in terms of controlling asthma? So of course, asthma is an inflammatory condition. I've shown you the trajectory of an exacerbation of asthma before, because we know that MART, and I'll show you some data on this in a second, prevents exacerbations. So when exposed to a trigger, the inflammation starts to rise, the symptoms start to follow that. And when those symptoms start to follow, because the only inhaler that you have, that you're hopefully taking regularly, but certainly when you start to get those symptoms, you reach for it to provide relief. Excited dog. And that inhaler, of course, contains the steroid as well. So you get the relief of the symptoms by relaxing the muscle, but you also start to tackle the inflammation early. If you remember before, the only additional steroid that was being provided was the oral steroid, and it was up here when the exacerbation had happened. But with MART, you get that increased dose of inhaled steroid through the reliever use, and it suppresses the inflammation early and prevents the exacerbation. So the symptoms settle, no need for the oral steroids. So is MART as good as it sounds? Does it do what it says in the tin? So here's one study I wanted to show you. So this is the proportion of patients that have had a severe exacerbation, so one requiring oral steroids. And along the bottom here is the time that they'd taken part in the study. And what we have is a maintenance and reliever therapy approach, MART, with these dashed lines. I appreciate they all look fairly similar. That's this bottom line. Budesonide formoterol, so that's the same combination inhaler, but used just twice a day with a SABA reliever. And then at the top, we've got salmeterol fluticasone, so a different combination inhaled steroid and long-acting beta agonist. And I think what you can clearly see is that the MART regime is associated with a reduced risk of exacerbation. So fewer people using the MART approach experience an exacerbation than both of the equivalent inhaled steroid dose fixed regime, so twice a day with a SABA reliever. And actually, when you look at the amount of inhaled steroid used, the people in the MART group, on average, use less inhaled corticosteroid than those in the fixed dose regimes. So of course, with a fixed dose, you have to give a constant level of inhaled steroid, which is designed to, one, control symptoms in the present, but two, prevent future risk of exacerbation. So you have to use a certain dose that you think is going to be enough when that person is exposed to a trigger to keep that inflammation at bay. Whereas with MART, it allows the patient to self-titrate their steroid dose to when they start to develop symptoms. So if normally, when they're not exposed to triggers, actually they only need a small dose of inhaled steroid to keep the inflammation at bay and keep their symptoms controlled, then they can be on that as the maintenance part of the regime. Because you know that when they are exposed to a trigger and some inflammation develops and they start to get some symptoms, they will use additional inhalations for relief, which will self-titrate up the inhaled steroid at that time. So the time they're getting the steroid that they need is the time that there's the inflammation there to treat. So on average, the dose required is slightly lower It's targeted at the time when inflammation is present to control that and treat it. Despite being on that lower than average daily dose, you get fewer exacerbations. So MART can also help to achieve asthma control, but at lower inhaled steroid dose. Bit of an echo. If you could just make sure you're on mute, that would be great. Thanks. So just to emphasize, this is not only seen in that one study. We've got a few different studies here. And this first graph, I think, is quite useful to see. This is the exacerbation rate, so number of exacerbations per 100 patients per year, with a fixed dose budesonide formoterol regime, with a SABA reliever. Actually using a formoterol reliever, so get rid of the SABA and using a LABA as the reliever, the formoterol, does actually reduce exacerbations a little bit. But when you use that combination of budesonide formoterol as a reliever, as well as for maintenance, you get that marked reduction in exacerbations. And that was then seen again in a different study. This one, I think the one that I in fact just showed you, where you're looking at the salmeterol fluticasone with a SABA reliever versus a MART approach. And here's some more studies showing exactly the same. And in fact, even against high dose inhaled corticosteroids, so where you've got those kind of severe asthma type doses of inhaled steroid, using a MART regime reduces your frequency of asthma attacks. This, because those previous studies, which is where the majority of studies have been done, is with budesonide formoterol. This is beclomethasone formoterol, so this was Foster that was being used. This is really just to show you that it works for beclomethasone formoterol as well. This is Foster with SABA as a reliever versus Foster with additional Foster inhalations as a reliever, and we can see that the proportion having severe exacerbation was significantly lower. So MART can prevent exacerbations. So when we're asking the question, is MART as good as it sounds? The answer is yes, it is. So how do we prescribe it? I think I said Fovumix earlier was beclomethasone formoterol. It's not, it's budesonide formoterol, but there is a new beclomethasone formoterol generic out, which I can't remember the name of right now. So how do we prescribe it? The guidelines have 3 different medicines on it, and these are your options. Fovumix is the most recent. It's on there because it's cheap, and it contains a combination of budesonide and formoterol, which can be used for maintenance and relief. Symbicort, of course, is the one that's been around the longest. These are the same doses, just different way that they're expressed. But that's budesonide formoterol as well, up to a maximum of 12 inhalations in a day. And then Foster, only licensed for MART of the 106 dose. The 206 dose is a high dose inhaled corticosteroid. So if you use that as MART, then you'd be ending up with very high doses of inhaled steroids. So the one that's licensed for MART is 106, and that's up to a maximum of 8 inhalations daily. So some good practice points about prescribing MART. First of all, the inhaler that the patient can and will use is the right inhaler for that patient. Where the option is there and they can and will use a dry powder, it seems reasonable to favor that over an MDI, because the environmental impact of dry powder inhalers is significantly less than the MDI, and actually most patients can use DPIs better. It's good practice to provide patients with a dedicated MART asthma action plan, and although at the moment Asthma UK don't produce one, they are working on it, and you can get dedicated MART asthma action plans from the inhaler companies, so the companies that make them, all of them do them. And through Sentinel, we've also produced a MART card, which can be accessed through the website. If you've got access to the Sentinel site, hullasthma.co.uk, and you've got the password, then you can download a MART card that patients can use as a quick reference, and allows you to put the detail of which drug they're on, what strength it is, what preventer dose they should be taking, and it also gives some details about what to do if they have an asthma attack on MART, and all those kind of useful hints and tips. It's important to provide good quality education, so bring the patient with you. We have to remember that most patients will have been given a SABA as their first inhaler that they've ever had. It makes them feel better when they take it. They see it on television all the time. They see their friends using it. And to them, it is the cornerstone of asthma treatment. And of course, that's a misconception, and we know that that's wrong and that the inhaled steroid is the cornerstone, but they don't understand that necessarily. And it's really important that we provide that understanding to them so that they know why we're starting them on a MART regime and why them using the SABA frequently can potentially signify that they're at increased risk of problems with their asthma, including attacks. And if you want support with that, then again, there's some patient-facing resources on the Hull Asthma website that go into a bit of detail about why clinicians might be worried about how frequently patients using their SABA and what the MART approach is and how it can be used. And that's written, but also some pretty amateur footage of myself and Helena and Joe in our offices trying to answer those questions briefly. The reason to avoid co-prescribing SABA with a MART regime is because it undermines the MART regime. If somebody has taken a SABA all their life when they get symptoms, when you convert them to MART and they start to get symptoms, the likelihood is they will still reach for the SABA inhaler. And when they do that, they will get temporary relief from their symptoms, but it won't target that inflammation early. If you remember that picture I showed you, the exacerbation, and therefore they'll still get that exacerbation. And the challenge with that is they might then come back to see you and you'll look and see, well, I put them on MART, but they're still exacerbating. Well, the question is, are they actually using MART? Because if there's a SABA there, there's a real chance that they're going to use that for relief. The last plea is when prescribing inhalers, please always prescribe by their brand name. It's better not to prescribe budesonide formoterol as a generic or beclomethasone formoterol as a generic, because what happens is when they go along to pharmacy, there is a chance they'll be given Duoresp rather than Symbicort or vice versa. And of course, the patient's then given a different inhaler that looks different. They're not sure if it's the right thing they should be taking and they don't know how to use it. So please always prescribe by brand name. My final plea with MART, but also with any change to asthma treatment, if at first you don't succeed, if the patient doesn't get on with it, or they have an issue, or they don't like it, don't give up. Don't go back onto what they were on before, because there was a reason that you changed it, and it was because their asthma wasn't controlled. So think about, is there an alternative inhaler I could try? So if maybe Symbicort Smart didn't work, maybe Foster MART would. Maybe if MART wasn't suited to them, you need to think about a different approach, but not de-escalating back to what wasn't working before either. So what if my patient still isn't controlled? So if we've still not achieved either of these points, so either they've still got symptoms, still needing to use their reliever an awful lot, or actually that might be okay, but they've had 2 or 3 exacerbations that are still needing treatment with steroids. So the first question I always think to ask is this asthma? And partly that reflects, was the diagnosis correct in the first place, or could this be something different? But secondly, are the current symptoms caused by asthma or not? It's not uncommon that we have patients referred up to secondary care with uncontrolled asthma despite optimal treatment, that actually we find that the asthma element of their disease is actually controlled and their symptoms are caused by something else. So BMI of 50, not moving around, not exerting, horrible gastroesophageal reflux and regurgitation of food and things like that. Vocal cord dysfunction, so they get hoarseness of the voice, difficulty breathing in predominantly with stridor or those kind of things. So it's always worth thinking about that, because we want to use the lowest possible doses we can to control the asthma. And what we end up with, if it's not the asthma causing the symptoms, is relentless escalation of asthma treatment, but never really getting the benefit. So if they're not responding how you think they should be, have a think and see if there might be something else that could be driving it. Other things to think about: can they take their inhaler correctly? You'll see I'm a bit obsessed with inhaler technique. So can they take it correctly, and are they taking it correctly? So back to the adherence side. If they're on MART, are they using the regime correctly? Have they got hold of a SABA inhaler and they've gone back to their old ways just because that's how they remember to do it? Do we need to step up treatment? And also, in what way are they uncontrolled? So is it that they've got symptoms but not exacerbating, or is it that they're exacerbating but with few symptoms, or vice versa, or both? Because the stepping up treatment for symptoms may be a bit different to if you wanted to target exacerbations. And of course, remember, we are always here. We might have long waiting lists, but we're always here, so you can always ask for help and refer. So that's covering MART and guidelines. I'm just going to fly through the next 5 minutes, a bit of an update on where we're at with Sentinel. For those of you that aren't familiar with Sentinel, if you're outside Hull or some of the areas in East Riding that are taking part, Sentinel was a piece of quality improvement work that we've done across Hull and some of East Riding to support guideline implementation and emphasising the importance of looking and identifying over-reliance on SABA and addressing that. And the two primary aims were firstly to improve outcomes for our patients with asthma, so those achieving asthma control, controlling symptoms and reducing exacerbations. And the second was to reduce the environmental impact of asthma. And that was predominantly through driving down SABA use, because 94% of SABA inhalers are MDIs, so have a high carbon impact, but also by actually improving control and reducing healthcare resource and appropriate use of dry powder inhalers. And this is what the intervention looks like. So healthcare professional education, those gold standards, which you may be familiar with, but they include things like assessing inhaler technique and checking adherence and not co-prescribing SABA with MART regimes, always using an ICS in asthma, and avoiding uncontrolled repeat prescribing of SABA. Targeted asthma reviews, so we supported through with a pharmacy service for that, patient support and education, and the data feedback and data monitoring. And just in terms of where we were, because we had 6 PCNs we were working across, I appreciate that the PCN 2, 3, 4, 5, 6 have now become 7 PCNs in those 5, but we've pretty much now finished. So in fact, next week, I think, we complete our final reviews in our PCN, and we'll be continuing to monitor outcomes from there. So where are we up to? So we've completed supported reviews across 28 practices, serving a population of 21,000 asthma patients. And when we look at the SABA use within our local practice populations, these are from the searches that were done on actually in practice. So this is all real data. A third of asthma patients had 6 or more SABA issues in the past month. And I think that's quite significant, given that we are seeing that, if you remember back to those graphs at the beginning, that 3 or more SABA, which over half had, were at increased risk of exacerbation compared to those on 0 to 2. But when you got to 6 or more, that risk was significantly higher. And in fact, when you get to 12 or more, 3,000 patients across Hull and participating East Riding practices had 12 or more SABA issues with their asthma. So, increased risk of exacerbation. And we look at the proportion of those that had 2 or more courses of oral corticosteroids, we can see that our data very much follows what we see in the national picture. The more SABA that our patients were picking up, the greater proportion of them had 2 or more asthma attacks in the last year by oral steroid prescriptions, and indeed admissions had gone up as well. So it all bears true. So what have we done in terms of reviews? We managed to support, so this is a third-party pharmacist. This doesn't include the hard work that those working in Hull have done reviewing their own patients, and we will get that data. But we're up to nearly 3,000 reviews, and about 90% of them had a change in their treatment. So either escalation, which was the majority, some de-escalation, but also changes in the regime, so appropriate use of MART where it's felt indicated. This data is slightly out of date by a few months. We're now up at over 17,000 fewer blue inhalers prescribed since we started Sentinel, when we compare it with comparative months the year before, and that grows by about 1,000 each month. So we're prescribing about 1,000 fewer SABA inhalers each month in Hull than we were before Sentinel. This is a graph showing the proportion of inhalers which are short-acting beta agonists. So the higher you are on this graph, the more SABA and the less inhaled steroid. And this was our pilot PCN out in East Riding. Ignore this blip because this was when 2 practices merged together. So that's a kind of anomaly in the data. But before the start of Sentinel, and then we started and we saw a rapid reduction in SABA prescribing with a slight increase in inhaled corticosteroid prescribing, which is what we'd like in asthma. And they're now gone from being one of the highest SABA prescribing PCNs in the country to, in fact, in the bottom 10%, which is a remarkable achievement. Just in terms of what this equates to, so about 15,000 SABA inhalers equates to about 530 transatlantic flights if you were going to go from Leeds to New York. So actually, it all adds up. And it's not all about SABA, although you might think it is, because that's what I've harped on about most of this time. When we look at preventer inhaler prescribing in the top right here, before Sentinel, the vast majority of preventer inhalers were MDIs. Now we're seeing greater than 50% of preventer inhalers are in fact dry powder inhalers. So the environmental impact likely even greater. Remember our guidelines, MART being the preferred regime for those on ICS LABA inhalers. Before Sentinel, only 90 patients across the practices were on a MART regime, or at least were identified as such. Now we're up at over 1,700, so certainly an uptick in guideline recommended treatment. And when we look at the kind of QOF measures of asthma before in grey and yellow and after, I think everybody would agree that there's been a significant increase in helping, or at least support in pandemic recovery in terms of the annual reviews. So in terms of where we are in Hull, so if we look at Hull specifically, Sentinel started in the East Riding PCN about here. And we had that kind of phased implementation. So each PCN joined. So our first Hull primary care network started about here. And of course, it took a little while to start to see that effect because this included all the other Hull PCN's data. But as we see more come on board, which is about every 2 or 3 months, we started to see this gradually start to shift and move down. And when we look at these blue lines, which are the national median here, and then these dotted lines being the deciles, and this is the top 10% of SABA users, we're still high, so there's still work to be done. This data does include COPD as well, so it's important to remember that. But I think what's clear is with all the work that you put in with Sentinel is that we've managed to really shift SABA prescribing down, increase appropriate use of inhaled steroid. And we're hoping that over the next few months, we're going to cross start to cross these deciles. So just to put this in perspective, to begin with, we in Hull CCG had the highest SABA use as a proportion of inhaled therapy in the country. And now 7% of primary of CCGs across the country have higher SABA use than Hull does. So I appreciate that we're still high and that needs to come down further, and there's still lots of work to be done, but we have seen a significant shift, and I really would encourage everybody to keep working hard at that. Helena, I promise I won't be long, 1 minute. So just looking at some incentives that come, Impact and Investment Fund, of course, supporting and promoting a reduction in the proportion of people with 6 or more SABA. So if you remember, across all our Hull and participating East Riding practices, the proportion of patients on 6 or more SABA was 36%. This was our pilot PCN, it was slightly higher at 39%, but following Sentinel, we've seen a steady reduction in that, now down to, I think, less than 18% of patients with 6 or more SABA. So not far off hitting the Impact and Investment Fund targets. And it's not cost an arm and a leg. So if we look at just open prescribing data, this is the cost of SABA and all ICS containing inhalers included in here, and looking at Hull CCG against other CCGs around the country. In fact, the cost on these medicines is still lower than average per 1,000 patient population than we're seeing elsewhere. So this shift in prescribing to increase MART use, trying to drive down SABA use, is not excessively expensive. So I'm about 5 minutes over, so I will stop talking and then happy to take any questions.
Thanks a lot, Mike. That was great. Really interesting and concise information about maintenance and reliever therapy. And it's been great to see the progression about the Sentinel project as well. Lots of PCNs on board, I believe now. Are we above 100 or so now?
Yep, so including Sentinel Plus, over 122. And in fact, because it's been so successful in terms of people taking it up, AstraZeneca have run out of funding for the pharmacy service to support it. So they're trying to work out how they can do that. But yeah, it's fantastic to see how it's grown.
Yeah, absolutely amazing. Thanks ever so much again, Mike, and I'll hand back over to Helena for the next part.
So we're going to open, have an open forum now, really. So it's a really good chance to ask any questions myself, Joe, Mike, about maintenance and reliever therapy, any troubles you may have had, anything that's maybe put you off or kind of given you some lacking confidence in regards to prescribing. So I know we have some questions already to put to the panel, so I'll broach them. But if you have any others, please do raise your hand or pop them in the chat. So a question from Ivan. Mike, you did actually broach this. So he asked, Foster 200, can it be used in MART? And are most ICS labbers with formoterol used for MART, or do they need a license?
Yep, so good question. So Foster 206 is high dose ICS. So if you were using that to the MART approach, you'd end up on very high doses of ICS. So I wouldn't do that. I'd use the Foster 100/6 for MART. In terms of other formoterol containing inhalers, so the budesonide and the beclomethasone ICS inhalers that contain formoterol are generally have a MART license at the appropriate doses. Things like flutiform, which contains fluticasone and formoterol, cannot be used as MART. And that's because fluticasone is quite a potent inhaled steroid, but it's also very fat soluble, and fat soluble drugs hang around in the tissue. So if you were to take additional inhalations of that, the steroid dose would accumulate, and you can end up with very high doses. So it's only the beclomethasone or the budesonide steroids combined with formoterol that are used for MART, and it tends to be in their lower dose preparations.
Great, thank you for that. Hope that answers your question, Ivan. I'm sure that was helpful to everybody. So Gillian Robinson, again, a really important question, I think. So, oops, it's just hopped away. So she mentioned about it saying not to co-prescribe a SABA in maintenance and reliever therapy. Is ICS LABA safe in an emergency? Really important question.
Yeah, so it's a good point. So a lot of people are worried about what happens in an emergency. So MART action plans do set out about how to use your MART inhaler in an emergency. Hopefully the slide that I showed you, which showed the effect of formoterol mapped against the salbutamol in terms of the speed of onset of action and its effectiveness, and will help to alleviate some of those concerns. So formoterol is an effective reliever and certainly can be used. Now, one concern that some people sometimes have is that if it's a dry powder inhaler, for example, are people able to use a dry powder in an emergency when you might not have that same inspiratory flow? And I think for the vast majority of asthmatics, inspiratory flow is not a problem. It is, of course, it's breathing out that becomes the most challenging for people with obstructive airways disease, not the breath in. But if you are worried about that, of course, there are MDI inhalers that can be used with MART. My concern with co-prescribing SABA is that you end up with people prescribed a MART regime that aren't actually using a MART regime and therefore don't get the benefit in terms of exacerbation reduction. And I suppose it's a bit like thinking, I mean, the kind of paradox, I suppose, is around about rescue therapies in general. And if you're driving a car, do you feel so reassured that you've got an airbag that you stop taking care to prevent that crash in the first place? And actually preventing the accident in the first place is going to be much more effective than relying on the rescue therapy when you get into a crisis situation. So first part of the answer is yes, formoterol is an effective reliever and it works quickly. Pick the right inhaler device for your patient. And the second part is, if we undermine the MART regime, then we're almost accepting that that this person should have a more frequent risk of exacerbation, and I don't think that's the right thing to do.
Mike, it's Jo. Just like to I totally agree with everything that you've said, and this, going back so many years, was challenging for myself and Helen in practice, thinking exactly the same as the Gillian has asked. But actual fact, Asthma UK are actually recommending to provide a blue inhaler and aero chamber for emergency if they're on a DPI device. So I think it's really important, like you said, to ensure the device is correct for the patient. And if they need PMDI for MART, use PMDI for MART and not prescribe a SABA in emergencies.
Indeed. Yeah. Or if you're desperate, provide them with a MART inhaler with a spacer that they can use in emergency, and they can use their DPI the rest of the time. So that there are options. I mean, if we look at national guidelines, for example, or we look at international guidelines. So GINA are the guidelines that are recommended in many parts around the world. And in fact, now GINA go as far to say that the recommended reliever inhaler in asthma is ICS formoterol. And that's from mild asthma all the way through.
Yeah.
So they don't recommend the use of SABA at all anymore as the first line reliever. So I suspect that that's the direction of travel.
Yeah, agreed.
Absolutely. And if anyone has any queries about that, there are papers available that do discuss patients who have used DPI inhalers in an emergency. And it's a huge proportion of that patient group that could still use and get suitable inspiratory flow in an asthma emergency. So if you'd like to have a look at those papers, do drop me an email and I'll be happy to get them over to you. The other thing is just to point out here is we need to be confident in our prescribing, which is one of the reasons we put this meeting on today, is that if we are feeling that we don't have the confidence in this regime or in the devices, the patients will feel that. So hopefully this will build some confidence with you and your prescribing and the way you can advise your patients. And again, Hull Asthma website we've got available here. There are videos available for you to watch. You can show to your patients as well to again explain the regime and the changes in devices. So this leads us on to Cheryl's question quite nicely. So Cheryl said she always goes straight for a PMDI and spacer rather than a DPI. Is a DPI better than the PMDI and spacer?
Yeah, good. It is a very good question. And my answer always is, I suppose, that it's not that it's better or worse, in that if the patient can use it, then that's the right one for the patient. Reasons to choose a DPI over an MDI. So dry powder inhalers have significantly lower carbon impact, which of course is an increasingly important thing in the current world. And for that reason, DPIs are promoted. I never promote a switching program for inhalers from one to another. So I certainly wouldn't suggest that you look at everybody on an MDI and go for a blanket, try and switch them to a DPI. It needs to be the right inhaler for the patient. And that needs to be an individual decision. That being said, MDIs are generally quite difficult to coordinate and therefore patients often struggle with them. Spacers are fantastic, and certainly the way that I would always prescribe an MDI inhaler. The slight challenge, particularly when you're talking about reliever use, is what you often find when the patient comes on to clinic is they pull out their MDI and you say, do you have a spacer? And you say, oh yes, it's on my bedside table. I use it for my puffs in the morning and in the evening, but while I'm out and about, it takes up too much room. And so they don't have it. So I think that the DPIs generally, I think once a patient's got the head around it and got used to it, are well tolerated and well used, particularly in an asthma patient group. That's my feel. And if patients can use both, then it would be reasonable to go DPI in the first instance. Just to give a bit of context, MDIs are a bit of a UK phenomenon in that in the UK, 94% of SABA are MDI. In Hull, about 97% are MDI. And if you go to Sweden, it's a significant minority of SABA that are MDI. The vast majority are DPI. And in fact, they have better outcomes there than we have here in terms of asthma. So it's interesting.
It is. And actually, in terms of teaching inhaler technique, for me to teach a really good PMDI technique, it can take 15 minutes, 20 minutes to get a technique really well perfected. And that's if they don't want to use a spacer, which often they don't, like Mike said, take out and about with them. Teaching a DPI technique takes much less time. I would say under 5 minutes, you can teach a good DPI technique. So again, in terms of teaching, patients do tend to pick up technique much quicker if they have that good inspiratory flow. But it's always what's right for the patient, isn't it?
Yeah.
So again, Ivan's made a comment, which we face as well. So educating some patients not to use their SABA daily because the doctor told me years ago to take 2 puffs in the morning of my blue inhaler every day is a challenge. So I don't know if you want to make any comment on that.
No, I would just agree. I've come across that as well, yeah, it's difficult to change people's behaviour. but there is no evidence that that does anything in terms of improving effectiveness of preventer inhalers. So it is just something that's been taught in the past and isn't so relevant now. And I think, you know, I never promote restricting access to inhalers that patients feel they need. I more promote trying to adjust what they need as a way to drive down use. But certainly, if it's just a habit thing, I'd be very tempted to say that they can't do it that way.
Yeah, I mean, it was a bit of a thing. I can remember when it was quite a long time ago now, I became a respiratory nurse specialist, but I can remember being told, take your blue reliever prior to taking your preventer inhalers, because you'll get the drugs much deeper into the lungs, or you get much better drug deposition. So we're moving away from those old wives' tales. If anyone else is still kind of working along that. So Laura Angus has and again, a really great question. Keen to understand how we keep this going. How do we change prescribing behaviours, and also how do we scale this up for all of the ICS?
Can I just come in on that and just explain what I meant? It's quite hard in the chat box. Just you know, interface. I just worry that interface will come in and do this, and then they'll go again. And just the queries that are coming through, and that just discussing that. You know, people are so used to using SABAs. How do we get that, you know, everybody on board with this? So when we start a patient, we start it with a MART and not, you know, then have to undo it further down the line.
Yeah. You know, I completely agree, Laura, and I think that's one of the challenges. So with Sentinel, we were very conscious. We didn't want it to be a interface come in, then they disappear, and it all goes back to status normal. And that's partly why this group is formed. Originally, it was through Sentinel, and why I'm here talking, and trying to kind of promote that and keep the message consistent. The other elements of Sentinel beyond the asthma reviews were designed to try and create longevity, I suppose, in the changes, and that does seem to be happening in that. You know, that pilot PCN, the interface intervention was only in the first 2 months. And we've seen that reduction has been sustained, and in fact, the proportion of SAB has dropped a bit even since then. So I think we've managed to gain a bit of momentum. How we can try and support this elsewhere? So we were trying to offer Sentinel with the interface resource around the patch to continue that. Obviously, we could only continue that as long as AZ kept funding the interface resource, and we don't have that now. So I think if there's other ways that we could work together, Laura, with the, you know, on the meds optimization side and the team, and continue that work, we'd love to. The other piece of work we're trying to pick up, so there's 2 streams. One is community pharmacy, so trying to support upskilling there, and also to help them to support change. And the second is around about system alerts. So Helena and Holderness Health have been doing a pilot where anybody who's had 3 or more SABA in the last year, 3 or more, is that right, Helena?
We're working through the 3 or more, yeah.
3 or more. It's automatically coming up with a box providing advice and instructions about what to do. So we're hoping that we'll be able to roll that out as well. But I really welcome your advice as well.
Take a more proactive approach to the patients, so they're being highlighted much earlier. So rather than just catching them when they've had an exacerbation and checking how many SABAs they've had, it'll automatically pop up in consultation, so we're aware of them. So that is helpful. And again, as I say, we're capturing the patients before they reach exacerbation rather than after. So there's still quite a few questions, and I'm aware of time. We've got 5 minutes left, so I'll just run through a few more. So Dr. Gosh had said, has anyone used group consulting to switch patients to MART to allow it to be more efficient? So I think that's a great comment.
Yeah, and I think a great idea. It's not something that we've used as yet. It may have been done somewhere, but not one that I'm as familiar with. So yeah, if that's an idea that you'd be interested in taking forward, we'd love to try and support that through the Sentinel side and maybe pick that up with you. So if you'd be interested in trying something like that, then drop myself or Helena or Joe a line, and we can try and pick that up with you.
Yeah, fantastic. Again, how do we engage people? So Laura again mentioned about community pharmacy. How do we get community pharmacists on board and getting that consistent message across?
So we're trying to tackle that through the LPC, but we're also working with the big names, so Boots, Lloyd's, etc. So we're trying to get them at a national level. But yeah, slow progress, I think.
Thanks for that. Let's have a little look. So I think in terms of talking about using MART and who can have it, who can't, what do we do in terms of licensing? So there's a couple of questions around that. So never a daft question, but if a patient's on 2 puffs twice a day of Foster, how many reliever puffs can they have?
Well, it licensed is up to a maximum of 8 puffs in a day, so that would be up to 4 additional puffs on top of the 4 that they're already taking. Of course, the duration of action of formoterol is a lot longer. So, you know, where with a SABA it wears off within a few hours. The LABA, the way that the long-acting beta agonists work, if you're really interested in the pharmacology of it, is that they kind of sit there within the membrane of the cells, so they're held next to the receptor for much longer. So the number of additional inhalations that you need is typically a lot less, even for the similar symptoms. Yeah.
And if a patient's in an asthma emergency, what advice would we offer?
Yep. So the kind of action plans tend to cover that. So similar to the usual things of, you know, loosen tight clothing, sit up comfortably, etc., and try and relax. And you take an additional inhalation of your MART inhaler, and you give it a few minutes. And if you're still symptomatic, you take another inhalation. And most importantly, you call for help if it hasn't settled in your first one and you think it is an emergency. And of course, all of the action plans that are provided say you keep going up until the maximum licensed dose, because that's what they say. I'm not aware of any patient in an emergency that's going to stop taking it after that set dose if they're still gasping for breath. But of course, they should have got an ambulance on the way by then, or be seeking other help. So it's really just like you would with a SABA and the advice you'd give there, but they use their MART inhaler instead.
Absolutely.
Do you agree with that, Selena? Joe?
I totally agree with that. Yeah, and again, happy if you're struggling with this, drop me an email. Always happy to chat. Always happy to chat this over any troubles that you have in regards to advising patients. And again, on Hull Asthma website, you have lots of videos about this. So just following on again, so if a patient's on Foster 206, do they keep the SABA? Oh, I've lost you, Mike.
Oh, sorry, my computer started making lots of strange noises, so I missed that question.
If a patient is on Foster 206, do they keep their SABA?
So the answer to that, I suppose, would be if they're on a fixed dose of Foster, which they should be at 206, then they would typically be on a SABA reliever. So that would be typically the regime. The question then is that person controlled on their Foster 206? So symptoms controlled, not getting variation, not getting attacks, then great. If they're controlled long enough, you might consider de-escalating them to a lower dose of inhaled steroid. If they're not controlled, then the question would be why. And they're already on a high dose of inhaled steroid if it's 206, 2 puffs twice a day. So do you need to add something else in? Or actually, could there be an adherence issue, in which case you might want to think about reducing the Foster strength to 106, putting them on that 2 puffs twice a day, but with a MART approach. And then you know that they're going to be getting their inhaled steroid because they'll use it when they get symptoms. So yes, if you're on 206, 2 puffs twice a day, then it would be a SABA that you'd use as a reliever at present. But you know, the question is that the right regime for them?
Absolutely. And then I'm just going to finish with this question because we're right on the money, but I think it's important. So from Jen Brownbridge, I'm a paediatric nurse and was kindly invited to the session. Thanks for being so informative. The question is, have you worked or educated your paediatric colleagues to change prescribing culture to MART earlier?
Yeah, good question. So, of course, I'm an adult respiratory physician. So the only children that I look after are the ones that I have to look after because they're mine. So I don't look after kids with asthma. That being said, I have done talks with pediatricians who do pediatric asthma, and we have talked about MART. And there has been discussions about a pediatric equivalent to Sentinel, trying to address SABA overuse in kids and looking at MART within that. but we haven't got that off the ground yet, just because Sentinel Adults has kept us busy enough at the moment. But I think it's a really good point.
Yeah, it is. And I'm very aware of time and that people will have to rush off to clinic. So I think we'll finish with the questions there, but a huge thank you to Mike. Thanks to Joe as well for joining us today.
The one last thing, just before we finish, because I have to go to clinic too, is if you're not from Hull or East Riding and you're interested in Sentinel or some of the education resources around it, Sentinel Plus is the kind of UK-wide equivalent. So if you type sentinelplus.info into the search bar, and then that will take you to the website, and it won't get you the resources, but there is a contact us feature, and it will tell you about the program, and it's got a contact us which will allow you to speak to somebody to help and get you.
Thank you very much.
Great.
We'll leave it there. We'll look forward to see you all at the next Asthma Forum. Thank you for supporting it, and I can see lots of people have enjoyed that, Mike, so thanks very much. Bye everyone.
Thanks, Mike. Thank you. Bye.
Bye.